I'm from Italy, and I'm a surgeon, a prosthodontist, and a periodontist. I practice in my office in Manfredonia, in the south of Italy, and I work with the University of Foggia. Today, I'm here thanks to Claudio from Osseotouch, who invited me to share my cases with you and to show the applications of the magnetic mallet. So let's go on and let's see what the magnetic mallet is. The magnetic mallet is a mallet, but there are several differences from a normal mallet. The first is that there is a magnetic acceleration inside the machine that reaches 5,000 G. So it is 5,000 times the acceleration of gravity. You have several surgical tips, and you can use them for different applications. Today, we will see only a small part of the many applications of the magnetic mallet. So it is like having two instruments in one. Imagine combining a mallet and all the other instruments you use with it. Another important characteristic of the magnetic mallet is that the tip has an excursion of only 1 millimeter. So, why the magnetic mallet? Better still, why not? Let's look at the several advantages we have with this machine. First, visibility. There is no irrigation. The machine works without water, so you can improve visibility during your surgery, especially in the lower jaw and in the posterior areas of both jaws. Then precision, because all the tips work axially in the same direction as the force. So the direction of the force vector is more predictable when you use this machine. Then control, because you have two hands to control the position of the tips. And it is very precise, especially when you have to cut bone and control the direction. And it is safe, because the forces are controlled, and the excursion of the tip is only 1 millimeter for every pulse. You have a pedal that gives the power to activate the machine. With the pedal, you deliver the impulse and produce the effect on the bone. It is ergonomic because it is two instruments in one, and it is very conservative. It is very conservative because you can expand and push the bone. If we talk about implant insertion, when we use a burr, we remove bone. We make a hole in the bone, taking bone away. With this machine, we don't remove bone. We expand, push, compress, and move the bone. Very conservative. Another advantage is that with the magnetic mallet, we have a low rate of benign paroxysmal positional vertigo. It is a very uncomfortable condition that you can avoid using this machine. This problem is caused by the movement of the otoconia, or otoliths, which produces vertigo in the patient after using a mallet. Not in every patient, but it is reported after surgical procedures such as sinus lift or split crest. With this machine, it is reported that there are no cases of this problem. So, no benign paroxysmal vertigo. In this historical moment, it is also important to underline that it is safer because we have no spray, especially during extractions. Normally, we use burs. In this case, we are not using burs, so we have no spray and no aerosol. During an extraction with burs, you can see all the blood and saliva pushed all around. With this machine, it is cleaner and safer. Let's also compare the effect of the magnetic mallet with a traditional mallet, which is the most important difference. This is a graph of the forces because this machine has 4 force levels, from level 1 to level 4. All the forces are delivered in 120 microseconds. As you can see from the graph, the pink line is the application time of the traditional mallet. It is a long time needed to produce the same effect. The other lines, the red, the green, and the blue, are the forces from level 1 to level 4 with the magnetic mallet. The force is higher, it is greater. So you can use more power, but the application time is dramatically shorter. The effect is produced in a very, very short time. And this is the reason for the safety of this machine compared with a traditional mallet. This is the reason why vertigo does not occur. And this is the good effect on the bone, because if you use the cutting tips, the cut is very fast and produces no heat. So, what is the magnetic mallet for me? An Italian masterpiece. I'm sure about that. Let's look at the applications. The first and most common application you can try is site preparation for implant insertion. Let's see, this case is courtesy of a colleague. If you want to ask something, I would have to open the chat. Sorry. Please leave the questions for later, because during the presentation, I can't read them. So this case is courtesy of a colleague. It is an aesthetic area in this patient. As you can see from the provisional restoration, we have a volume defect, an original volume defect. And to have a good result, we need to increase the volume. How can we increase the volume? We can increase it with a split crest, a bone graft, or a soft tissue graft, a connective tissue graft. But in this case, the doctor used only the magnetic mallet to produce bone expansion. Increasing the volume without using burs and without any graft. This is the result with the provisional restoration. And with the definitive abutment, we can see the volume he achieved using only the mallet. And this picture was taken at a 4-year recall. Let's watch a video. This video shows How to prepare the site. We start by elevating the flap. We start as in a normal implant. Procedure. After the crestal incision, we elevate the flap to expose the bone. We start with the first tip. This tip allows us to choose the point of insertion, the prosthetic emergence, the correct position of the implant, and the direction of the implant. For every pulse, the instrument goes 1 millimeter into the bone. On the instrument, we have laser marks that show the depth, so you have to know the length of every mark. Pulse after pulse, you start to create a hole in the bone, and you produce an expansion of the bone. If the bone is soft, you also get densification. You increase the density of the bone. So, starting from the first tip, we move to osteotomes of a wider size. To reach the size of the final burr, we would use for implant insertion. Rotating the insert, we can withdraw it from the bone. At the end, we insert the implant, and you can see how the bone is shaped. There is an expansion that produces an increase in bone volume. So we can finish, and during the insertion of the implant, we can check the torque. In every case, we have a high torque because the bone is condensed, compressed by the osteotome, and often, if not every time, very often, we reach excellent implant stability. In fact, in this case, we can place a healing screw at the time of surgery, and we can end the procedure with the suture. This is a normal, simple case of implant insertion. As you can see in this case, this was a lateral incisor. Here, using only the mallet, starting from a very narrow crest, we increased the volume using wider inserts, wider tips to reach this kind of preparation. So we turned a narrow crest into a wide crest, able to receive a narrow implant, but without any kind of bone regeneration or grafting. I like to call all these procedures bone shaping. We can shape the bone in every kind of situation. We can push the bone, we can widen the bone, we can change the height of the bone, as in the following cases. Let's look at this case. This is a very challenging case because this patient came to my office with this bridge. The bridge had failed because of the fracture of both abutments. It is a 5-unit bridge on 2 abutments. The abutments were the canine, so tooth 1-3 and tooth 1-7. Let's look at the X-ray, but we also have to check the 3D scan. The important thing is that this patient, Anna, is 65 years old and very emotional and frightened. This patient was very very scared of surgery, but she asked for a non-removable solution. No removable prosthetics, only a new bridge, and of course, we needed to place implants. And because she was so emotional and frightened, she asked for as little surgery as possible. So these are the periapical X-rays, the 2D images that show the fracture of teeth 1-3 and 1-7. This is the 3D scan. As we can see on the molar side, we have enough bone, and the same at the root of the canine, tooth 1-3. But in the middle, we have no bone. There is a narrow crest. So, if we want to place an implant in the middle area, we need to expand the bone. We need to perform a split crest. So let's look at the different images. You can see that the first and the second image are the molar area. At the molar, we have only 6 millimeters of bone height. But it is very wide. It is 10 millimeters wide. In the middle area, there is a narrow crest. It is less than 4 millimeters, but it seems to be high, 14 millimeters. The point is that moving distally, we have a decrease, a dramatic decrease in height. Because there is the sinus. The sinus is waiting for us, so it is very dangerous to go straight with the burs, because you may end up inside the sinus. And in the last image, we see the situation at the root of tooth 1-3. There is enough bone, but there is a very thin buccal plate. And we have to try to preserve that bone, starting from the extraction and finishing with the implant placement. This is the clinical view. After removing the bridge was floating on the gum, so we had to remove the roots and proceed with implant insertion and, if possible, with immediate loading as well. These are the extractions performed with the extraction inserts and the magnetic mallet. The magnetic mallet allows us to remove the root, preserving the bone without fracturing it and saving all the very thin buccal plate. This is the intraoral view after the extraction. And let's see what we have to do to place the implant here. This is the first implant, tooth 1-3. At 1-3, we must not follow the direction of the root. We have to change the direction of the root. And to choose and guide the first drill, we usually use a lance. Burr. In this case, we used the first tip. The first tips allow us to choose the best direction for the implant. So we start with the first tip. Once it engages the bone, we can change the direction gently. And after that, we can change it further. And using a wider tip, we can complete the preparation and guide the implant into a perfect prosthetic position, because I wanted to finish the case with a screw-retained bridge, and I wanted the screw access hole in the palatal area. So in this case, we can check the direction with the axis of the tip. And this is the 3D scan after implant insertion. You can see how that little piece of the insertion on the last tooth in the molar area, tooth 1-7, This was the situation. We had enough width, but we needed to perform a mini sinus lift, a crestal sinus lift, to place an implant. So we start with the first insert, the first tip, to create the first hole. After that, we use the second one, and we can go deeper, because with the first insert, we have to stop below the sinus. With the second insert, we can push the bone upwards. After this, we change the tip and use a wider one to push the bone higher. And with the wider tips, we can move the bone, the floor of the sinus, higher to reach with the last insert the final length at which we want to place the implant. After that, we can insert the implant in the best position with a sinus lift performed in a very gentle and safe way. This is the X-ray after implant insertion. You can see that I only fractured the sinus floor because I didn't need to lift the sinus more than 1 millimeter to place the implant. This is a wide implant, 8.5 millimeters long, but the most challenging site was the intermediate implant. The implant was in position 1-5. Here we have narrow bone and we have to widen it, but we also have the sinus, so we have to combine procedures. This is a cocktail, starting with a different insert, this one from the split crest kit. This is the cutting tip, and we can cut the bone. So we start cutting the bone exactly in the middle. After that, we use the expanders. With the first expander, which is wider, we start to increase the width of the bone. After that, we use the second expander to move the bone and produce the green stick fracture of the buccal plate. After this, we need to lift the sinus. So we change kit. And we start with the osteotomes. We don't start with the first osteotome. We start with the second, then the third, then the second, the first, and the fourth. Then we can insert the implant. I can show you the final image with the dramatic change in the bone. I widened it and I pushed the sinus floor upwards before inserting the implant, using only the magnetic mallet. These are a few images taken during the surgery. The insertion of implant 1-3 and the insertion of implant 1-7. During the surgery, I try to perform several procedures at the same time. Here I am, grafting connective tissue, because on the first implant, 1-3, I wanted to protect the implant and increase the volume. So in the same surgery, I also performed a connective tissue graft to increase the thickness of the soft tissue over implant 1-3. This is the bridge. The intermediate implant, 1-5, did not reach enough stability for immediate loading. And this is the provisional bridge that I loaded at the same time. And these are other images. On the intermediate implant, you can see how large the piece of sinus floor is that I fractured and pushed upwards. Other images, this is 1-3 and this is 1-5. I want to show you another case. This case is osteodistraction to avoid a sinus lift. This is the beginning of the procedure. The patient came in with this bridge and asked me to place implants in order to make a new bridge. To restore her with a bridge on implants. This is the situation. The first route was long enough for me to restore it with a traditional crown, so I wanted to place an implant. In the next site, at 1.5, the premolar area, and I decided to remove the root of tooth 1.7. In this situation, what options do we have? Of course, if we want to place implants here, 2 implants, everyone usually thinks about a sinus lift. We have different options to avoid the sinus lift, but until yesterday, I always performed a sinus lift before placing 2 implants. Today, we often hear about tilted implants, so we also have the option of placing the implants this way. But there are several problems. The first problem on implant 1.5 is that you may touch the root of tooth 1.4 with the implant, and it is also possible to enter the sinus with the burs. The other problems concern the posterior implant, 1.7. With the posterior implant, this angulation is very difficult to achieve, but the biggest problem you can meet is when you have to restore with a bridge. If you want to screw the bridge down, and whenever possible, I prefer to finish the case with a screw retained bridge, you need multi-unit abutments. As you know, multi-unit abutments have a very small screw, and broken screws inside the bridge are common. So if we can avoid that option, for me, it is better. Another problem is that when you restore with a bridge, you have some difficulty with cleaning because you have large spaces. Very large interproximal spaces and food impaction. So let's find a different way to avoid both the sinus lift and the tilted implant, and that is with the magnetic mallet. I'll show you a video of this surgery, performing the osteodistraction. You enter with the first and the second insert in this direction. You have to enter from distal to mesial to engage as much bone as you can with the first insert. As if you wanted to reach the root. After this, you have to rotate it. Rotating the insert, we produce the fracture of the sinus floor, which is moved distally. We go on changing the insert, moving to a wider one, and doing the same thing. But in this situation, we start in a more mesial direction. And after reaching depth during the insertion, we can rotate and move the bone distally. In this case, we also had another problem. The problem was the length of the abutment of the root. For the feral effect, we also needed to perform a crown lengthening, and whenever so in this case, I performed the extraction of tooth 1.7 the sinus lift, the crestal sinus lift at 1.7, then the insertion of implant 1.5. With the osteodistraction to reshape the sinus floor and avoid a sinus lift. With a lateral approach, and in the same surgery, I also performed the crown lengthening to lengthen the abutment and to finish with a crown with a good ferrule effect. I want to show you the surgery. We are now a little past the halfway point of our presentation. This video shows in detail the procedure and the use of the magnetic mallet for bone distraction. So this is the beginning. We start with the extraction kit. The extraction is possible because of the wedge effect. When the insert enters the ligament space, this tip cuts the ligament and creates space for the following tips. So when the tips go in, the bone is compressed and detached from the root. And as you can see, in the end, the root comes out easily, preserving all the bone. The inserts are very strong, so you can use them like traditional elevators. But often you don't even need to apply force. So after the extraction, we start with the flap design. And in this case, we also had to perform periodontal surgery. So the flap is designed for a crown lengthening. We have different incisions, from buccal to palatal, because on the buccal side, we have to preserve the keratinized tissue, while in the palatal area, we can remove some soft tissue. And it is very important to choose the right direction of the incision, because we want to reduce the thickness of the palatal flap. So we have the first flap and the second flap. After the elevation, we remove this piece of gum. But in this case, we have to keep this piece of gum because at the end, I will use it. So we go back to the buccal area. We clean everything. We remove the interdental papilla. And we start with the first tip. The first tip, as you can see, goes from distal to mesial, because we want to be sure to stay in the native bone. So the direction is strongly angled. It is not orthogonal. The direction is as if I wanted to reach the root of tooth 1-4. This way, I am certain that I am inside the bone. I don't want to be anywhere near the sinus. It is around 45 degrees. I check the length because I want to place a 10mm implant. As I am showing you, I start from the distal side, but during the insertion, I move more mesially. I want to push the bone with the tip of the insert. I want to push the bone distally. I want to move the sinus floor. I'm going in. I want to reach the laser mark at 11 millimeters because my implant has to be placed 1.5 millimeters below the bone level, subcrestally. So I'm going deeper and deeper. And as I go deeper, I move the insert meshally to make it more upright. I'm changing the tip. And again, I start from the distal side and I push gently. I push gently. We must not rush. We have to let the bone expand and move. And we have to produce the fracture of the sinus floor. I change the insert. I move to a wider one. And now I want to go straight. Because I started from the distal side, but the implant I want to place has to be upright to allow me to restore with a screw-retained bridge without using multi-unit abutments. So I'm pushing. And as you can see, for each activation of the magnetic mallet, there is an excursion of 1 millimeter. The patient feels no pressure. The patient only hears the noise of the machine, the sound of the machine. But he doesn't feel the impact, the pressure. So I reach the depth. I check the length. This is 11, the 11 millimeter mark. And I want to go deeper because I want to place the implant subcrestally. I'm sure the direction is right. And at the end, I can go ahead with the implant. I place some collagen because I don't want the implant threads after the fracture to produce a laceration of the sinus membrane. I'm inserting the implant, and I place it very deep because I have to restore after a crown lengthening. At the back, at tooth 17, I need only to fracture the floor. I have another 10 minutes to finish my presentation. If you have any questions, you can write them in the chat, and I'll answer everyone. After fracturing the floor, I use a novel approach. It is called the crick technique, and it allows us to elevate the floor simply by screwing in the implant. So I use the mallet to fracture the sinus floor. And then, with the implant, I elevate the sinus. The stability was good. I place the healing abutment, and then I move to the root for the crown. Lengthening, there is nothing special here. It is a traditional crown lengthening. We want at least 3 millimeters, but 4 is better, of root to have better stability. So we start by removing the bone. You have to reshape the buccal and interdental areas. And then we can prepare the root. In this way, you remove the periodontal attachment from the root. And you have the final preparation of this area. And this way, you don't have to touch the tooth again. It is single-stage surgery. At this point, now I'm using that piece of gum as a connective tissue graft. I'm grafting this tissue over the first implant, because in this area, the ridge was narrow. And in these cases, I always graft some connective tissue. And it is always better to do it at the same time. This is to prevent later aesthetic problems. And also to prevent peri-implantitis. So we completed the surgery with a periodontal suture. This is an external mattress suture to stabilize the tissue and compress it against the bone. I don't use any graft in these cases. I only reshape the bone. I compress and push the bone. And I leave the space to be filled by the blood clot. So these procedures are also cheaper for the patient, because we don't have to use any kind of graft. We use the patient's own bone and the patient's own soft tissue to improve the pink aesthetics. I place only a little collagen to stabilize the clot, because the more stable the clot, the better the healing. But what I want to show you is the final result, using the magnetic mallet to reshape, to recontour the sinus floor. This is the collagen that I placed around the healing screw, because I want the tissue to heal over the collagen. So let's see. This is a 1-month recall. And you can see how I changed the sinus from this situation at the beginning, from the red line to the green line. I completely changed the contour of the sinus using only bone distraction. I have a good implant position for a screw-retained bridge. And I also performed the crown lengthening on the root of tooth 1-4. These are some pictures taken at the time of the surgery. And this is the healing at only 7 days. You can compare it with a conventional sinus lift. It is dramatically less invasive. Talking again about site preparation. Sorry for these pictures, but this case was dramatic. This patient was a class 3, a skeletal class 3, and he asked for a fixed prosthetic bridge with immediate loading on implants. In these cases, we have no bone. The only areas with bone were the anterior incisor area and the premolar area close to the sinus. And in these cases, I planned an all-on-4 technique. You can see that the bone was only in the area of the incisive bone. And immediately behind it, we have the sinus. So how can we place the implants? Preserving the sinus and without grafting bone? With the magnetic mallet. This was a class 3, so we have very strong forces in this area. And to protect the immediate loading, I decided to place 2 more implants in the tuberosity area. In the tuberosity, as you know, there is very low quality bone. Tuberosity bone is not good for immediate loading. And often, when we place an implant there, we can't load it because the torque is very low. So I decided to place the implants using the magnetic mallet in the tuberosity bone as well. This is the last case. I want to show you the clinical images. This is the situation. It looks good, but after the flap elevation, you can see it was dramatic. We had bone only in the anterior area, and at the back, there was the sinus. So I used the burs only in positions 1-1 and 2-1. But at the back, I started with the magnetic mallet. And I finished with the magnetic mallet. These are the implants at the time of insertion. And you can see that in the distal bone. I placed 2 more implants in the tuberosity. These implants were placed after preparation with the magnetic mallet, and the bone went from a D4 to a D2 because I reached 50 Newton centimeters of torque. So I was able to load these 2 implants as well. I placed the multi-unit abutments. This is the moment of the impression with a particular technique. And this is the delivery of the provisional restoration. But the most important thing is the final X-ray. After the provisional loading, you can see implant 1-4, which is very close to the sinus. And this was possible because I didn't use the burr. I used only the mallet. The mallet doesn't open the sinus. The mallet pushes the sinus. And you feel safer placing the implant very close to the sinus. The other factor is the increase in bone density. By increasing the bone density, you often, if not often, very often, can load the implant immediately. I want to thank you for your kind attention. And now I can close the presentation and read your questions. All right. So, if you have any questions, contraindications. Thank you, everyone. Can you perform this kind of sinus lift if there is sinusitis? Yes, sinusitis does not allow you to perform a traditional sinus lift where you have to elevate the membrane. But with the magnetic mallet, we never work on the membrane. We work on the bone. And the bone, after using the osteotomes, is pushed up together with the membrane. So I don't think it is a problem to use it with sinusitis. Of course, we have to distinguish between chronic sinusitis and acute sinusitis. Because if it is acute sinusitis, you first have to treat the sinusitis. And after that, you can perform your surgery. Contraindications. The only contraindication to the use of the magnetic mallet is bone density. You can't use it in D1 or D2 bone. In D1, it is not possible. You have to use the burr. This is why almost every time I use the magnetic mallet. In the upper jaw, but I use it less often in the lower jaw. Because if the bone is too hard, you can't shape it. You have to use the burr. And after that, you can start using the magnetic mallet. Any more questions? Do you use any bone graft in a crestal sinus lift? There are two kinds of approach. There are two approaches. Some clinicians use a graft. I don't like it. I don't like it. I prefer to use the bone, reshaping the bone. Because biomaterials are good for increasing the volume. But whenever you can avoid using biomaterials, for me, it is better. You get healing with native bone, not the hybrid bone that you usually see after healing. When you use a bone graft. So I never use a bone graft with the magnetic mallet. In a crestal sinus lift, I use grafts only in guided bone regeneration and in the lateral approach to the sinus. Is it the same as the piezo? No, it is dramatically different. The piezo is completely different because the magnetic mallet works like a mallet. So you push the bone, the piezo cuts and removes the bone. So in the end, with the magnetic mallet, you keep 100% of the original bone. With the piezo, you lose something. And with the piezo, you can only cut the bone. You can't push and split it. You have to cut the bone, and then you have to use the osteotomes. It is better to use one machine to cut and widen the bone at the same time. Reshaping and resorption after extraction. Resorption is the same as with any kind of distraction. I have performed distraction for many years, and I have seen little resorption. It is around 5% by volume. With the magnetic mallet, in my opinion, you have less stress on the bone. There is no heating, no warming. You don't increase the temperature, so you are more gentle. And for me, the resorption is lower compared than other instruments. For more complicated cases, do you use a guide? Yes, I use a guide, but mainly for the position, for the prosthetic position. When I have a complicated case, I prefer to open everything and be guided by my brain and my hands. Versa drills and the mallet. Versa drills are good. I have Versa drills too. But the mallet, sorry. Versa drills use a motor, so you have an increase in temperature. There is more thermal effect on the bone than with the mallet. The mallet does not produce a thermal effect. What is the minimum bone height? For a crestal sinus elevation, that depends on personal experience. Usually 5 millimeters is a good starting point, because you can place an 8 millimeter implant. Today, evidence-based medicine shows that 8 millimeters is enough for an implant. And the most common bone height is 5, 6, or 8 millimeters. So very, very often we can place an implant of 8 or 10 millimeters with a crestal approach only in those cases which are not so frequent in our practice. With 1 or 2 millimeters, in those cases, you have to perform a lateral approach. Any more questions? All right. So, if that's all, I hope I have shown you something interesting about a different way of looking At bone surgery, I like to perform the same procedures, but in a different and safer way with this machine. For any kind of question, I have left my contact email. And you can write to me. Do you use the magnetic mallet in the mandible? Yes. Often in the posterior mandible. In elderly women, you have a cortical bone, and inside it a D4. When you read the cross-section of a CBCT, you see the black bone. Black bone is a disaster for implant insertion in the mandible, so it is good to make the first hole with a burr. Only to open the very hard cortical bone. After that, using the magnetic mallet, you get osteodensification, and with osteodensification, you can place implants with a high torque, 40-50 Newton centimeters. And this is very important when you need to load the implant immediately. But these cases are not very common, because in the mandible, we often have D1 and D2 bone, so I prefer to use it in the maxilla. All right. So, thank you for your kind attention. And I hope to meet you all in the future, when this difficult moment is over. I hope you will stay safe at home and enjoy your life. Goodbye, everyone. The magnetic mallet uses advanced technology for minimally invasive surgery. Try it yourself.